Hello dear friends, how are you doing today? I hope you are doing well. Welcome to a new question about dermatology. A 22-year-old male sex worker comes to the emergency department with an erythematous skin rash. He tells you that it began on his scalp and is now spreading to involve his face, neck, and the flexure surfaces of his arms and legs. He has no significant past medical history and takes no regular medication. Blood pressure, pulse, and temperature are all normal. Respiratory and abdominal examination is unremarkable. There are extensive erythematous scaly plaques. The outlying skin is greasy and there are areas of yellow-brown crusted material. Which of the following tests is most important in this situation? A. Autoimmune profile. B. Herpes PCR. C. HIV testing. D. Skin scrapings for microscopy and culture. And E. Syphilis serology. Okay, here we have a 22-year-old male sex worker, and his occupation is really important. He's a sex worker, comes to the emergency department with an erythematous skin rash. The patient has erythematous skin rash, and he tells that the rashes started from his scalp and now spreading to his face, neck, and flexure surfaces of his arms and legs. The patient's past history is not significant. The patient's vital signs are stable, and examination has no any important findings. But we can see extensive erythematous scaly plaques, the overlaying skin, which is greasy, and there are areas of yellow-brown crusted material. The diagnosis here can be seborrheic dermatitis. Seborrheic dermatitis is usually common in patients with HIV or in patients with Alzheimer's disease. Okay, this patient, according to his work, which is a male sex worker, in suspicion to HIV, then the HIV testing is important for this patient. Here we are going to explain about it. This man's presentation is consistent with seborrheic dermatitis, and given his occupation as a male sex worker, there is a high risk that this may be associated with HIV infection. P24 antigen testing may be useful in the early stage of HIV infection for screening. In the latest stages of disease, serology for anti-HIV antibodies is useful. The extensive plaque count against the being of fungal infection, which would usually be confined to one area, rules out taking skin scrapings as being useful. Seborrheic dermatitis may be associated with autoimmune thyroid disease, although we are given no evidence to support a diagnosis of thyroid dysfunction here. Syphilis is unlikely given there is no history of primary syphilis infection, and herpes PCR is not useful in determining the underlying cause of seborrheic dermatitis. Okay, seborrheic dermatitis. Seborrheic dermatitis is a chronic, relapsing inflammatory skin condition that mainly affects sebaceous or oil-rich areas such as the scalp, face, chest, and back. And it's important. It's relapsing. The disease is relapsing, and we must manage it if the relapse is acute. Usually it's common in sebaceous or oil-rich areas such as scalp, face, chest, and back. It's common in both infants, which we call it cradle cap in infants, and it's also common in adults. The exact cause is not fully understood, but is linked to Malassezia years our growth. Malassezia for especially our growth in excess sebum and abnormal immune responses. As we said, it's common in patients with HIV because of the decreased their immune system. It's due to Malassezia years overgrowth, excess sebum, and an abnormal immune response. Presentation of seborrheic dermatitis. In scalp, we can see dandruff, mild form, greasy scales, itching, and redness. In face, involvement of eyebrows, nasolabial folds, and beard area with erythematous patches and fine greasy scales. In chest and trunk, we can see salmon-colored patches with greasy scales. In infants, we can see thick yellow greasy crust on the scalp, which we call it cradle cap, and sometimes extending to the They are per era. In general, itching, irritation, and recurrent flares often worse with stress, fatigue, or cold weather. Management of seborrheic dermatitis in general measures gentle cleansing of affected areas, avoid harsh soaps or irritants, stress reduction since stress can trigger flares, and topical treatments. Antifungal shampoos or creams like ketoconazole and cyclopirox reduce Malassezia years, and topical corticosteroids, which are low potency and short-term use, or topical corticosteroids can reduce the inflammation. Topical calcineurin inhibitors like tacrolimus or pimecrolimus is useful in sensitive areas like the face and folds. And medicated shampoos containing selenium sulfate, zinc parathion, or coal tar preparation for scalp involvement can be helpful. Systemic therapy for severe or refractory cases like oral antifungals like itraconazole or fluconazole, and occasionally systemic anti-inflammatory treatment can be needed. Here we can see their seborrheic dermatitis or head in this lady. Here we can see seborrheic dermatitis with the involvement of eyebrows, eyelashes, and the face of this patient. Here we can see the cradle cap on the head of this baby. Here we can see the involvement of face, eyebrows, and nasolabial fold of this baby with seborrheic dermatitis. Okay, it was a short explanation about seborrheic dermatitis presentation and management in a patient with involved of the face, head, and scalp with seborrheic dermatitis. Thank you for your attention.